Welcome back, future nurses. With our daily 3 videos challenge today, we are focusing on one of the most common and challenging conditions in cardiovascular nursing, congestive heart failure. This disorder occurs when the heart is unable to pump blood effectively to meet the body's needs, leading to congestion in the lungs, fluid retention in the tissues, and decreased organ perfusion. Clients may present with shortness of breath, fatigue, edema, and exercise intolerance. And without proper management, heart failure can become a progressive and life-limiting condition. In this session, we will explore the essential aspects of nursing care for clients with congestive heart failure, including accurate assessment of symptoms, monitoring fluid balance, medication administration, oxygen therapy, and dietary modifications such as sodium and fluid restriction. We will also discuss client education, lifestyle adjustments, and the nurse's role in preventing complications and promoting adherence to treatment. By the end of this lesson, you will not only understand the pathophysiology and manifestations of heart failure, but also feel prepared to provide compassionate, evidence-based care that improves both survival and quality of life for your clients. Before we continue with the next NCLEX topic, let me tell you about something that has changed the path of over 100,000 nursing students. Many of them were in the exact place you are right now, anxious, preparing, and hoping to pass. They chose the ultimate NCLEX crash course, and today they are practicing nurses. So what's inside this one-stop program? You get live interactive classes, easy-to-watch recorded lectures, 5,000 practice-style questions, 30 full-length practice exams, PDF notes and eBooks for fast revision, a ready-to-use student planner, and complete breakdowns of NGN questions. You deserve the same success story. Scan the QR code now or use the link in the description to enroll instantly. Plus, you'll get free access to practice tests, NCLEX quizzes, and PDF notes, along with Telegram and WhatsApp study groups to keep you on track. Let us now dive into another NCLEX-style practice question that challenges your understanding of cardiac anatomy and blood flow pathways. The nurse is reviewing cardiac anatomy with a group of nursing students, and the instructor asks the students to correctly trace the flow of oxygenated blood through the left side of the heart and into systemic circulation. The question is, which sequence of structures represents the correct pathway? Here are the options that must all be used: the aorta, the left ventricle, the pulmonary veins, the left atrium, and the mitral valve. The correct sequence is pulmonary veins to left atrium to mitral valve to left ventricle to aorta. Now, let us carefully go through the rationale step by step. The pulmonary veins are the only veins in the body that carry oxygenated blood. After oxygen exchange occurs in the alveoli, blood rich in oxygen returns to the heart through 4 pulmonary veins, 2 from each lung. From there, blood enters the left atrium, a thin-walled chamber that serves as a reservoir and conduit. During ventricular diastole, it fills passively, and during atrial systole, it contracts to provide the final atrial kick that pushes blood through the mitral valve. Next comes the mitral valve, also called the bicuspid valve, which opens during diastole to allow blood into the left ventricle and closes during systole to prevent backflow. If this valve becomes stenotic or regurgitant, serious hemodynamic issues occur. After the valve, blood flows into the left ventricle, which is the thickest and strongest chamber of the heart. The left ventricle generates high pressures needed to overcome systemic resistance and eject blood effectively through the aortic valve into the aorta. Clinical relevance here is that left ventricular dysfunction leads to pulmonary congestion and symptoms such as orthopnea or frothy sputum. Finally, the blood moves into the aorta, the largest artery in the body, which distributes oxygenated blood throughout systemic circulation via its ascending, arch, thoracic, and abdominal branches. Disorders like aortic aneurysm or dissection can compromise this vital flow. This order is correct because the left-sided heart maintains a one-way high-pressure circuit that ensures oxygen-rich blood reaches systemic tissues. Any disruption, whether from valve disease, atrial fibrillation, or ventricular dysfunction, compromises systemic perfusion and oxygen delivery. From a clinical perspective, the left ventricle directly impacts cardiac output, while blood pressure reflects its effectiveness in pushing blood into the aorta. Disorders to keep in mind include mitral stenosis, which causes left atrial enlargement and pulmonary hypertension, left ventricular failure that leads to pulmonary edema, and aortic stenosis, which results in hypertrophy and symptoms such as syncope or angina. Stand coast. Pearl. Always remember the phrase lungs, LALV, life. This means blood flows from the lungs into the left atrium, then to the ventricle, and finally out into the aorta, which serves as the lifeline for systemic circulation. Let us transition into this important NCLEX-style practice question by focusing on a real-life hospital scenario. A 78-year-old client is admitted with a diagnosis of left-sided heart failure, and during the initial health history, the nurse needs to prioritize recognizing the very earliest clinical manifestation. The question asks, which symptom is most likely to appear first in this client? The options presented are anorexia, dyspnea, nausea, and headaches. Now, the correct answer here is option 2, dyspnea. Dyspnea, or shortness of breath on exertion, is the hallmark and usually the earliest symptom of left-sided heart failure. This occurs because when the left ventricle fails to contract or relax effectively, pressure builds up in the left atrium and then backs up into the pulmonary circulation. As fluid seeps into the interstitial spaces of the lungs, oxygen exchange becomes impaired, leading to early complaints of shortness of breath during activity. Over time, this may progress to orthopnea, where the client feels the need to sit upright to breathe, or paroxysmal nocturnal dyspnea, where sudden nighttime awakenings occur with a sensation of air hunger. Clients often describe needing multiple pillows or waking up gasping for breath. This makes dyspnea a red flag symptom for early detection of left-sided failure. On the other hand, option 1, anorexia, is not an early sign of left-sided heart failure, but is more commonly associated with right-sided failure. In right-sided heart failure, blood backs up into the venous system, causing hepatomegaly, ascites, and gastrointestinal venous congestion. These result in abdominal fullness, early satiety, and poor appetite. Although anorexia may eventually appear in advanced or biventricular heart failure, it is not an initial symptom when only the left side is failing. Moving to option 3, nausea, this is also tied more to right-sided failure due to hepatic congestion and impaired gastrointestinal perfusion. In isolated left-sided failure, nausea does not occur early, though severe hypoxemia or pulmonary edema may sometimes cause generalized gastrointestinal discomfort. NCLEX test takers must clearly differentiate. Pulmonary congestion equals left-sided symptoms, while systemic congestion equals right-sided symptoms. Finally, option 4, headaches, are not characteristic of heart failure at all. Headaches are more closely associated with hypertension, migraine, or increased intracranial pressure. Although chronic hypertension is a risk factor for developing heart failure, the symptom of headache does not represent an early sign of left ventricular dysfunction. To integrate this clinically, remember that the pathophysiology of left-sided failure primarily involves pulmonary congestion, so symptoms include dyspnea, orthopnea, cough, and crackles. In contrast, right-sided failure involves systemic venous congestion, leading to peripheral edema, hepatomegaly, ascites, and anorexia. For NCLEX purposes, the earliest symptom to recognize in left-sided heart failure is always dyspnea on exertion. Nursing priorities should include assessing breathing patterns, auscultating for crackles, monitoring oxygen saturation, and keeping track of baseline weight to detect early fluid retention. Here is the clinical pearl to lock it into memory. Dyspnea is not just shortness of breath. It reflects the left ventricle's inability to meet systemic oxygen demands, leading to pulmonary congestion. Recognizing this early can prevent escalation to acute pulmonary edema, which presents with frothy pink sputum and severe hypoxemia. Stand coast. Pearl to remember. Left equals lungs, right equals rest of the body. The earliest sign of left-sided failure is dyspnea, while the earliest sign of right-sided failure is edema and anorexia. Hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it, and you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can rewatch anytime, 5,000 practice-style questions, 30 practice tests, eBooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait, scan the QR code or click the link in the description now. You will instantly unlock free study content including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Let us now step into an advanced NCLEX-style scenario. A 72-year-old client with a long history of hypertension and coronary artery disease has been admitted to the hospital with worsening shortness of breath, orthopnea, and swelling of both lower extremities. On examination, the nurse notes crackles at the lung bases, jugular venous distension, and the client reports being unable to sleep unless propped up on 3 pillows. These are classic signs of decompensated congestive heart failure. The question is, to optimize respiratory function and decrease preload, which position should the nurse implement immediately? Here are the options to consider. Option 1 suggests supine with knees slightly bent. Option 2 offers side lying on the right side. Option 3 recommends side lying on the left side. And finally, Option 4 proposes semi-Fowler's position. The correct answer is Option 4, semi-Fowler's position. Placing a client in semi-Fowler's, where the head of the bed is elevated about 30 to 45 degrees, is the most effective way to improve ventilation and decrease cardiac workload. In this position, abdominal contents shift downward, relieving pressure on the diaphragm and allowing the lungs to expand more fully. This expansion enhances alveolar gas exchange, easing hypoxemia and reducing shortness of breath. Upright positioning also decreases venous return to the heart, lowering pulmonary venous congestion and helping relieve the client's dyspnea. It is especially helpful for clients with orthopnea, who often require several pillows just to breathe at rest. In contrast, Option 1, supine with knees bent, is not appropriate. Lying flat increases venous return, raises pulmonary venous pressure, and worsens pulmonary edema, leading to more severe dyspnea. Bending the knees does not correct the problem and may even push abdominal organs upward, further impairing breathing. Moving to Option 2, side lying on the right side, we find that while it may redistribute pulmonary blood flow, it does nothing to reduce preload or relieve pulmonary congestion. In fact, dependent lung areas may become more congested, worsening oxygenation. Similarly, Option 3, side lying on the left side, often causes discomfort in clients with cardiomegaly or left ventricular dysfunction. The heart rests closer to the chest wall, producing palpitations, chest pressure, and worsened dyspnea, while offering no benefit to lung expansion. Clinically, nurses may also use mid-Fowler's, high Fowler's, or the orthopneic position, where the client leans forward onto a bedside table, for even greater comfort and lung expansion. In severe cases, positioning is paired with oxygen therapy, diuretics such as furosemide, vasodilators like nitroglycerin, and even morphine to reduce preload and pulmonary congestion. Importantly, orthopnea itself is a classic sign of congestive heart failure and should always be documented, as it reflects the severity of pulmonary congestion. And here is the Stan Coast Pearl. Positioning is not just about comfort in heart failure, it is truly life-saving physiology. Elevating the head of the bed reduces preload, improves lung expansion, and relieves pulmonary congestion. Always remember the rule: the more upright the client, the easier the breath. Moving ahead into another clinical scenario. Consider a 68-year-old client who has recently been diagnosed with left-sided heart failure. The client is admitted to the cardiac step-down unit after presenting with exertional shortness of breath, difficulty breathing when lying flat, and frequent nighttime awakenings due to sudden breathlessness. On assessment, the client appears restless, is breathing at a rate of 28 breaths per minute, and repeatedly asks the nurse if they are going to suffocate. Now the critical question arises: based on the nurse's understanding of psychosocial responses to acute decompensated heart failure, which emotional reaction is this client most likely to exhibit? Here are the options to consider. The first option is depression. The second option is anxiety. The third option is anger. And the fourth option is stoicism. The correct answer is Option 2, anxiety. Clients experiencing acute left-sided heart failure often develop pulmonary congestion due to elevated left atrial and pulmonary venous pressures. This leads to shortness of breath, orthopnea, and sometimes sudden nocturnal breathlessness. These episodes of breathlessness not only reduce oxygenation, but also trigger the sympathetic nervous system, activating the fight or flight response. As oxygen levels drop, the client experiences air hunger, panic, and a heightened fear of suffocation, which are classic features of anxiety. Anxiety here is both physiologic, due to hypoxia and the catecholamine surge, and psychological, due to the overwhelming fear of not being able to breathe. Nursing care should therefore include positioning the client in semi-Fowlers, providing supplemental oxygen, administering prescribed diuretics, and offering reassurance with calm communication. Addressing anxiety is not optional. It is vital because stress itself raises myocardial oxygen demand and can worsen heart failure symptoms. Looking at the other options, depression, though very common in clients with chronic heart failure as they cope with lifestyle limitations and poor long-term prognosis, is not the predominant response in an acute setting. Anger may be seen in some clients who are frustrated by their disease, but it is not the expected reaction when breathlessness is the main stressor. Stoicism, where a person minimizes or hides their symptoms, is unlikely here, because clients in severe respiratory distress rarely remain calm or detached. Instead, they show restlessness and visible anxiety. Here's the Stancoast Pearl for this question. Dyspnea in left-sided heart failure is not only a respiratory issue but also an emotional emergency. Anxiety results from both low oxygen and the intense fear of suffocation. Managing this anxiety with reassurance and oxygen therapy is just as important as giving diuretics. As we continue our journey through another critical NCLEX practice scenario, imagine a 72-year-old client admitted to the step-down cardiac unit with acute decompensated left-sided heart failure. The client has been placed on 2 liters per minute of oxygen via nasal cannula, and 30 minutes later, the nurse must reassess to determine if the therapy is effective. The key question is, which assessment finding provides the most reliable and objective evidence that oxygen therapy has truly improved the client's condition? The possible answers include the client's face appearing flushed, a capillary refill time of 6 seconds, the client reporting, "I am feeling better," or the apical pulse being less bounding. The correct answer is option 4, the apical pulse is less bounding. This is because in heart failure, decreased cardiac output leads to sympathetic activation, resulting in tachycardia and bounding pulses. When supplemental oxygen is administered, arterial oxygen levels rise, tissue hypoxia decreases, and sympathetic drive reduces, causing the apical pulse to feel less bounding and less rapid. This is an objective and measurable indicator of improved perfusion and reduced cardiac workload. Now, if we look at why the other options are incorrect, flushed skin cannot be trusted as a reliable measure, since it may occur with fever, stress, or medications, making it non-specific. A capillary refill of 6 seconds actually indicates worsening perfusion rather than improvement, since normal should be under 3 seconds. Meanwhile, the client saying, "I feel better," represents subjective data, which is important to note but does not outweigh objective evidence in evaluating the effectiveness of oxygen therapy. Remember this NCLEX Pearl. Objective findings such as pulse quality, oxygen saturation, capillary refill, or level of consciousness always outweigh subjective statements when determining treatment outcomes. To tie it together, oxygen therapy in heart failure is meant to relieve hypoxemia, reduce myocardial stress, and decrease sympathetic workload. And the best way to know it is working is by focusing on clear physiologic evidence. Stancoast Pearl. When evaluating oxygen therapy, never stop at how the client feels. Focus instead on how the heart and body respond. A less bounding apical pulse is your strongest signal that oxygen is easing the heart's workload. Let us now transition into a critical NCLEX-style practice question that highlights both physiological and psychosocial nursing priorities. A 68-year-old client with chronic left-sided heart failure is admitted to the step-down unit after suddenly developing acute pulmonary edema, presenting with severe shortness of breath and frothy pink sputum. As the nurse prepares for an urgent transfer to the intensive care unit, the client becomes visibly agitated and expresses, "I am terrified. I feel like I am going to die." At this moment, the question is, which is the most appropriate nursing action? The options provided are as follows. Option 1 states, remain at the bedside, offer reassurance, and use therapeutic communication to decrease the client's anxiety. Option 2 suggests immediately notifying the physician regarding the client's fear and requesting additional orders. Option 3 recommends telling the client firmly, "You will be fine. We are transferring you to intensive care for closer monitoring." And finally, Option 4 prioritizes charting the client's statement and collected data before transfer to the intensive care unit. The correct answer is Option 1, remain at the bedside, offer reassurance, and use therapeutic communication to decrease the client's anxiety. Now, let us carefully review why this is the correct action. Remaining with the client is the most therapeutic and evidence-based nursing response during a moment of acute fear. In severe pulmonary edema, anxiety and feelings of impending doom are common due to respiratory distress and hypoxia. Leaving the client alone can escalate panic, further elevate heart rate and blood pressure, and increase myocardial oxygen demand. The nurse's calm presence provides immediate safety and emotional stability, while therapeutic communication reduces sympathetic activation and helps the client remain cooperative during life-saving interventions such as oxygen therapy, diuretics, or ventilatory support. This action aligns with NCLEX frameworks of psychosocial integrity and therapeutic communication, which emphasize meeting emotional needs alongside physical care. Looking at Option 2, it may seem logical to notify the physician, but this is not the immediate priority. Physicians handle medical interventions, while the nurse at the bedside is responsible for immediate psychosocial support. Escalating the statement without addressing the client's fear delays the urgent intervention needed in the moment and represents poor prioritization. Turning to Option 3, telling the client, "You will be fine," may appear comforting, but it is actually false reassurance, a non-therapeutic communication technique. This approach invalidates the client's fear, shuts down further expression, and erodes trust. NCLEX consistently emphasizes that nurses must avoid false reassurance because it minimizes real emotional distress. Finally, Option 4, charting the client's statement before transfer, does not take priority. While documentation is important, it should never come before ensuring the client's immediate safety and psychological stability. Leaving a frightened client during pulmonary edema to document would compromise care and reflects poor judgment according to Maslow's hierarchy and ABC frameworks. Here is the high-yield clinical pearl to remember. Clients with pulmonary edema often describe a sense of impending doom due to severe hypoxia. The first-line psychosocial intervention is to remain with the client and provide therapeutic presence, which reduces anxiety and prevents sympathetic overdrive. On the NCLEX, never choose responses that include false reassurance, ignoring emotional needs, or charting before addressing immediate client safety. Always remember, Maslow's hierarchy and ABCs guide us to protect both physiologic oxygenation and psychological safety above all else. Hey, future nurses! Before we jump into the next NCLEX topic, I want to pause and give you something that might completely change your prep strategy. Imagine walking into the exam room with total confidence, knowing you have the ultimate NCLEX crash course backing you up. This isn't theory. Over 100,000 nursing students have already passed with it. So what's inside? Interactive live classes, binge-worthy recorded lectures, over 5,000 practice questions, 30 full-length tests, eBooks and notes for last-minute revision, a ready-to-use student planner, and NGN-style questions explained in detail. This is not just another review course. It's the complete package. Scan the QR code or tap the link in the description right now to join. As a bonus, you'll get free resources like PDF notes, quizzes, and practice tests, plus access to our study communities on Telegram and WhatsApp. Let us begin this clinical scenario with a smooth transition. A client with worsening left-sided heart failure has been admitted to the intensive care unit for close observation. The nurse recognizes that in this delicate condition, even small shifts in fluid status can severely impact both pulmonary function and cardiac workload. This leads us to the critical question: which parameter should the nurse monitor on a daily basis to most accurately evaluate fluid retention and the effectiveness of therapy? Here are the options for consideration. Option 1 suggests monitoring pupil response. Option 2 recommends assessing peripheral edema. Option 3 focuses on observing appetite, and Option 4 emphasizes monitoring weight. The correct answer is Option 4, weight. Daily weights are the most reliable and sensitive indicator of fluid balance in left-sided heart failure. A sudden change of more than 2 pounds, or 0.9 kilograms, within 24 hours, or more than 5 pounds, or 2.3 kilograms, in a week, indicates significant fluid retention. This occurs because reduced renal perfusion activates the renin-angiotensin-aldosterone system, leading to water and sodium retention. The consequence is increased pulmonary venous pressure, which worsens pulmonary edema, crackles, and shortness of breath. On the other hand, a steady decline in weight reflects effective diuresis and response to therapies such as loop diuretics, angiotensin-converting enzyme inhibitors, or angiotensin receptor blockers. For ICU nurses, monitoring daily weights allows early intervention, preventing dangerous complications like acute pulmonary edema and severe hypoxemia. Looking at why the other options are not correct, let us start with option 1, pupil response. While pupillary checks are valuable in neurological assessments, they are not directly connected to heart failure. Pupil changes more often reflect intracranial pressure, cranial nerve involvement, or certain medication effects, but they do not reveal anything meaningful about fluid balance or heart failure treatment response. Now, shifting to option 2, peripheral edema. Although swelling is a common symptom in cardiac disease, it is more strongly linked with right-sided heart failure due to systemic venous congestion. In left-sided failure, the main concern is pulmonary congestion, not peripheral edema. Furthermore, edema develops over days, making it a delayed and less precise marker. Weight measurements, in contrast, provide an immediate and quantifiable picture of fluid status. Moving forward to option 3, appetite. It is true that in severe heart failure, clients may lose appetite, feel nausea, or experience early satiety due to gastrointestinal congestion. However, these symptoms are vague, subjective, and not reliable for daily monitoring of fluid retention. While appetite should still be assessed as part of overall care, it cannot replace the accuracy of daily weights in critical ICU management. To tie this all together with some clinical insights, in left-sided heart failure, the failing ventricle cannot pump blood effectively, which causes backflow into the pulmonary veins. This leads to pulmonary congestion and impaired oxygen exchange. The best intervention is to monitor weight consistently, guiding diuretic therapy, fluid restrictions, and medication adjustment. A red flag sign to remember is a weight gain of more than 2 pounds in 24 hours, which often signals the onset of acute pulmonary edema, a life-threatening complication. Stand Coast Pearl. In heart failure, the scale is your stethoscope. Daily weight changes uncover fluid overload earlier than lung sounds or visible edema, giving nurses the chance to act before pulmonary edema escalates into a crisis. Let us transition now into another critical NCLEX-style practice scenario that emphasizes the importance of electrolyte monitoring during aggressive diuretic therapy. A client with acute pulmonary edema has been receiving high-dose intravenous furosemide for rapid diuresis, and the nurse is carefully monitoring laboratory values to identify life-threatening complications. The question is, which laboratory value should the nurse report immediately to the healthcare provider? Here are the options for consideration. Option 1 presents sodium at 137 milliequivalents per liter. Option 2 shows potassium at 2.5 milliequivalents per liter. Option 3 provides chloride at 97 milliequivalents per liter. And option 4 lists bicarbonate at 25 milliequivalents per liter. The correct answer is option 2, potassium at 2.5 milliequivalents per liter. This indicates severe hypokalemia, which is one of the most dangerous side effects of loop diuretic therapy. Normal potassium values fall between 3.5 and 5.0 milliequivalents per liter, and a value below 3.0 places the client at very high risk for deadly cardiac arrhythmias, such as ventricular tachycardia, premature ventricular contractions, and ventricular fibrillation. Hypokalemia also prolongs cardiac repolarization, increases the chance of digoxin toxicity, and impairs muscle function, which may even weaken respiratory muscles. In a client already struggling with pulmonary edema, adding respiratory fatigue could rapidly worsen oxygenation and become fatal. Because potassium is essential for cardiac conduction, skeletal muscle activity, and acid-base stability, a level this low requires immediate provider notification, initiation of cardiac monitoring, and preparation for potassium replacement therapy. On the other hand, let us consider why option 1, sodium at 137 milliequivalents per liter, is not correct. This value falls squarely within the normal range of 135 to 145 and therefore does not require urgent reporting. While loop diuretics can cause sodium loss, concern typically arises only when sodium levels drop below 130, at which point neurological symptoms like confusion or seizures may appear. Next, let us examine option 3, Chloride at 97 milliequivalents per liter. Normal chloride levels range from 96 to 106, which means this value is only minimally decreased. Though chloride helps maintain acid-base and fluid balance, such a mild drop is not life-threatening and does not take priority over the critical hypokalemia. Finally, let us evaluate option 4, bicarbonate at 25 milliequivalents per liter. Since the normal range is 22 to 28, this value is entirely normal and does not reflect any immediate acid-base disturbance. While diuretic use may lead to metabolic alkalosis over time, this particular lab does not signal danger. From a nursing perspective, loop diuretics such as a furosemide are life-saving in acute pulmonary edema because they dramatically reduce preload and pulmonary congestion. However, they waste potassium, sodium, magnesium, and calcium, making electrolyte surveillance a top priority. Severe hypokalemia can lead to arrhythmias, muscle weakness, ileus, digoxin toxicity, and even respiratory failure. Key nursing interventions include placing the client on cardiac monitoring, notifying the healthcare provider immediately, anticipating intravenous potassium chloride replacement, and following strict infusion guidelines, such as administering no faster than 10 milliequivalents per hour through a peripheral line. Stancoast. Pearl. Loop diuretics clear the lungs in pulmonary edema, but unchecked potassium loss can silence the heart. Always prioritize potassium monitoring because dysrhythmias can end life far faster than fluid overload. Before we move on to the next NCLEX topic, let me share something that could be the game changer in your journey. If you are determined to pass the NCLEX on your very next attempt, the ultimate NCLEX crash course is exactly what you need. This program has already helped more than 100,000 nursing students achieve success, and now it's your turn. Here is what makes it powerful. Daily interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks and PDF notes for quick revision, a ready-to-use student planner, and detailed NGN question breakdowns in comprehensive lectures. It is not just a course, it's your all-in-one NCLEX toolkit. Simply scan the QR code now or click the link in the description to enroll instantly. You'll unlock free content like PDF notes, practice tests, and NCLEX quizzes, plus access to our Telegram and WhatsApp groups filled with even more free resources to keep you ahead. Let us now move into another NCLEX-style practice question, this time focusing on the clinical recognition of heart failure, which is one of the most high-yield assessment topics in nursing exams. The question asks, a nurse is assessing a client with suspected decompensated heart failure. Which clinical finding most strongly supports the presence of right-sided heart failure? Here are the options to consider. Option A suggests jugular vein distension observed at a 45-degree head elevation. Option B points to bradycardia with a heart rate of 52 beats per minute. Option C presents a dry, hacking cough with exertional dyspnea. And Option D highlights a flushed, erythematous facial appearance. The correct answer is Option A, jugular vein distension observed at a 45-degree head elevation. Now, let us break this down carefully. Jugular vein distension, or JVD, is the hallmark bedside sign of right-sided heart failure. It occurs because the failing right ventricle cannot effectively pump blood into the pulmonary circulation, leading to systemic venous congestion. When assessed at a 45-degree angle, distended jugular veins reflect elevated right atrial pressure, usually greater than 8 to 10 millimeters of mercury. Clinically, this finding is linked with systemic signs such as peripheral edema, hepatomegaly, and ascites. For this reason, JVD is considered one of the strongest and most reliable physical findings of right-sided volume overload. Shifting our attention to Option B, bradycardia, with a heart rate of 52 beats per minute, is not typically associated with heart failure. In fact, most clients in decompensated states exhibit tachycardia because the sympathetic nervous system increases the heart rate in an attempt to maintain cardiac output when stroke volume is impaired. Bradycardia, instead, would suggest conduction abnormalities, drug effects such as beta blocker, toxicity, or advanced atrioventricular block rather than right-sided failure. Looking at Option C, a dry, hacking cough is actually much more consistent with left-sided heart failure. In this condition, blood backs up into the pulmonary circulation, leading to congestion, pulmonary crackles, dyspnea, orthoapnea, and paroxysmal nocturnal dyspnea. The cough occurs because of fluid accumulation in the lungs, not systemic congestion. Therefore, while cough is significant, it points to left-sided failure and not to right-sided pathology. Finally, option D, a flushed, erythematous face, is not a recognized sign of heart failure. Instead, it may be linked with uncontrolled hypertension, fever, or carbon dioxide retention, as seen in some clients with chronic obstructive pulmonary disease. In heart failure, the skin is more likely to appear cool, pale, or cyanotic due to impaired circulation and poor oxygen delivery. Here is the Stan Coast Pearl for this question. Right-sided heart failure is marked by systemic congestion. So always think of jugular vein distension, hepatomegaly, ascites, and peripheral edema. Left-sided heart failure, by contrast, produces pulmonary congestion, dyspnea, orthopnea, pulmonary crackles, and nocturnal cough. Remember to assess jugular vein distension at a 45-degree angle for accuracy, because the supine or upright position can give misleading results. Distinguishing between right and left-sided failure is a cornerstone in clinical practice since management strategies must be tailored to relieve congestion on the affected side while addressing overall cardiac output. Gliding into our next high-yield calculation, a client with chronic atrial fibrillation is prescribed digoxin to improve contractility and control the ventricular response. After the digitalizing dose reaches therapeutic levels, the provider orders a maintenance dose of digoxin 0.12.5 milligrams by mouth once daily, while the pharmacy dispenses tablets labeled 0.25 milligrams each. Here are the choices to weigh carefully. Option A says 1 tablet, option B says 1/2 tablet, option C says 1/4 tablet, and option D says 2 tablets. The correct option is option B, and the correct answer is 1/2 tablet. Because using the universal medication formula, amount to give equals desired dose divided by dose on hand multiplied by quantity, 0.125 milligrams divided by 0.25 milligrams multiplied by 1 tablet yields 0.5 tablet, which translates to 1/2 tablet. Shifting from math to safety, remember that digoxin has a narrow therapeutic index with a typical therapeutic serum range of 0.5 to 2.0 nanograms per milliliter. So even a small dosing error can push a patient toward toxicity, which is why giving a full tablet would double the order and increase risk, while a 1/4 tablet would underdose and reduce effectiveness. Moving into assessment, always check the apical pulse for 1 full minute before administration and hold the dose for a heart rate less than 60 beats per minute in adults, less than 70 in children, and less than 90 in infants. And review electrolytes because hypokalemia and hypomagnesemia potentiate toxicity, whereas hypercalcemia can also heighten risk. Early toxicity tends to announce itself as anorexia, nausea, vomiting, abdominal discomfort, and visual changes such as yellow halos or blurred vision, while later findings can include bradycardia, dangerous arrhythmias, and confusion. Zooming in on the distractors, option A, 1 tablet equals 0.25 milligrams, and therefore doubles the prescription. Option C, 1/4 tablet equals 0.0625 milligrams and is subtherapeutic. And option D, 2 tablets equals 0.5 milligrams and is 4 times the ordered dose. Tying this back to NCLEX thinking, do the calculation, verify vital sign thresholds, scan labs for potassium, magnesium, and calcium derangements, and keep the classic toxicity symptoms at the ready. And as a final professional habit, use an independent double check when splitting tablets for high alert medications. Stan Coast. Pearl. Digoxin is a precision drug. Every fraction counts. So calculate deliberately, confirm the apical pulse, and think electrolytes before you give it. Let us now move into an important NCLEX-style question that highlights a fundamental safety principle in cardiac pharmacology. The scenario is this. A nurse is preparing to administer digoxin, also known as lanoxin, to a hospitalized client with chronic heart failure. The critical question asks, which assessment is the most essential for the nurse to perform immediately before giving this medication? Here are the options to consider. Option A states that the nurse should check the client's apical heart rate for 1 full minute. Option B suggests measuring the client's blood pressure in both arms. Option C proposes assessing the client's bilateral lung and breath sounds. And finally, option D highlights listening to the client's S1 and S2 heart sounds. The correct answer is option A, checking the apical heart rate for 1 full minute. Let us carefully break this down. Digoxin directly influences the cardiac conduction system by slowing conduction through the atrioventricular node and enhancing vagal tone. This mechanism places the client at risk for bradycardia and life-threatening dysrhythmias. Because of this, nurses must count the apical pulse for a full 60 seconds before giving the drug. If the rate is below 60 beats per minute in adults, below 70 beats per minute in children, or below 90 to 110 beats per minute in infants, the dose should be withheld and the provider must be notified. In addition, the nurse should watch for irregular rhythms such as atrioventricular block, premature ventricular contractions, or atrial tachycardia with block, since these may signal early digoxin toxicity. Missing this vital step could result in syncope, ventricular arrhythmias, or even sudden cardiac death, which is why it is a classic NCLEX-tested safety checkpoint. Now turning to the incorrect options, let us first consider option B, which is measuring blood pressure in both arms. While digoxin can indirectly increase cardiac output by improving contractility, it is not primarily an antihypertensive or vasodilator drug. Blood pressure assessment remains important in overall cardiac care, but it is not the determining factor for withholding or giving digoxin. Moving on to option C, which is bilateral lung and breath sound assessment. This is indeed a crucial part of heart failure monitoring, as crackles may suggest pulmonary edema and guide diuretic therapy. However, lung assessment does not dictate whether digoxin should be administered or withheld, making it less critical in this context. Lastly, option D, listening to S1 and S2 heart sounds, can certainly reveal murmurs, gallops like S3 or S4, and other indicators of cardiac disease. Yet these findings do not determine the immediate safety of digoxin administration. For example, hearing an S3 indicates volume overload, but does not contraindicate the use of digoxin. To extend this discussion clinically, nurses must always be alert for signs of digoxin toxicity. These include bradycardia, gastrointestinal symptoms like nausea, vomiting, and anorexia, neurological changes such as confusion, and visual disturbances often described as yellow or green halos. Electrolyte balance plays a key role, as hypokalemia from loop diuretics heightens sensitivity to digoxin, while hyperkalemia may indicate severe toxicity. In life-threatening cases, the antidote is digoxin immune fab, also known as Digibind, especially when ventricular dysrhythmias, severe bradycardia unresponsive to atropine, or dangerous hyperkalemia occur. Here is your high-yield Stan Coast Pearl. Always remember that counting the apical pulse for a full 60 seconds is like checking a stoplight before crossing the street. If the number is less than 60, it is a red light. Do not proceed, hold the medication, and notify the provider. Forgetting this safety step is one of the most common traps tested on the NCLEX, and knowing it could save both points on your exam and lives in your practice. Moving into our next NCLEX-style practice scenario. Imagine a client who has been receiving digoxin therapy for chronic heart failure and suddenly develops new symptoms. The nurse suspects digoxin toxicity, and the critical question becomes, which clinical finding would the nurse most likely expect to observe? Here are the options to consider. Option A suggests anorexia and nausea. Option B mentions dizziness and insomnia. Option C proposes pinpoint pupils and double vision. And option D lists ringing in the ears and itchy skin. The correct answer here is option A, anorexia and nausea. Let us carefully explore why. Gastrointestinal symptoms such as anorexia, nausea, vomiting, and diarrhea are the earliest and most common signs of digoxin toxicity. These occur because digoxin increases vagal stimulation of the gastrointestinal tract. As toxicity progresses, the client may begin to experience neurological changes like confusion, drowsiness, fatigue, and weakness. Visual disturbances are also a hallmark, particularly blurred vision, yellow or green discoloration, and the classic halo effect around lights. From a cardiac perspective, the danger escalates as digoxin toxicity can cause bradycardia, atrioventricular blocks, or even life-threatening ventricular arrhythmias. This is especially concerning because digoxin has a narrow therapeutic index, with normal serum levels ranging only from 0.5 to 2 nanograms per milliliter. Electrolyte imbalances such as low potassium, low magnesium, or high calcium can further sensitize the myocardium and accelerate toxicity. In severe cases, the antidote Digoxin immune fab, also known as Digibind, may be required to reverse toxicity and protect the heart. Now, looking at the other choices, option B, dizziness and insomnia, may appear tempting but is not the best fit. While dizziness can occur secondarily to bradyarrhythmias or hypotension, insomnia is not a hallmark feature of digoxin toxicity, making this option incorrect. Moving on to option C, pinpoint pupils and double vision point more toward other conditions. Pinpoint pupils are classic in opioid overdose, while double vision is more closely linked to neuromuscular disorders such as myasthenia gravis. Digoxin toxicity, by contrast, produces color disturbances and halos rather than diplopia. Lastly, option D, ringing in the ears and itchy skin, does not align with digoxin either. Tinnitus is a red flag for salicylate toxicity such as aspirin overdose, and itching is generally associated with allergic reactions or hepatic and renal dysfunction, not with digoxin. Stand coast. Pearl. Always remember that digoxin toxicity whispers first through the gut with anorexia, nausea, and vomiting before shouting through the eyes with halos and finally striking the heart with dangerous dysrhythmias. Now, let us move on to an advanced NCLEX-style practice question that focuses on evaluating outcomes in a client with chronic heart failure. A 68-year-old client has been admitted with the nursing diagnosis of decreased cardiac output related to tachycardia, decreased stroke volume, and increased vascular volume. The interdisciplinary team establishes the goal that the client will demonstrate improved cardiac output by discharge. The question asks, which of the following assessment findings best indicates that this goal has been met? Here are the options to consider. Option 1 states that the client maintains vital signs within age-appropriate normal limits. Option 2 suggests the client experiences a weight loss of no more than 5 pounds in 24 hours. Option 3 proposes that the client shows a reduction in peripheral edema at the ankles. And option 4 mentions that the client produces a 24-hour urine output of 1,000 milliliters. The correct answer is option 1, where the client maintains vital signs within normal parameters. This is the most accurate and reliable indicator of improved cardiac output. Remember, cardiac output equals stroke volume multiplied by heart rate. When output improves, compensatory changes, such as tachycardia, hypotension, or narrow pulse pressure resolve, and vital signs stabilize. This objective evidence reflects that the heart is pumping effectively, perfusion is adequate, and the workload on compensatory systems, such as the sympathetic nervous system and renin-angiotensin-aldosterone system, has decreased. In NCLEX testing, measurable outcomes like stable vital signs are always prioritized over subjective findings. On the other hand, let us consider why the other choices are incorrect. Looking first at option 2, the idea of a weight loss of no more than 5 pounds in 24 hours is actually unsafe. A loss this rapid suggests excessive diuresis, which can cause hypovolemia, hypotension, and renal impairment. The safe goal is usually 1 to 2 pounds per day. Therefore, this option does not truly reflect improved cardiac output. Next, turning to option 3, decreased peripheral edema might seem like progress, but it is subjective, varies by examiner, and can be influenced by factors unrelated to cardiac output. Although helpful in clinical monitoring, it is not as reliable or specific as stable vital signs. Finally, option 4, which lists a urine output of 1,000 milliliters in 24 hours, is inadequate because the expected amount in adults is generally 1,500 to 2,000 milliliters daily. Anything less suggests reduced renal perfusion, which means cardiac output has not fully improved. Stand coast. Pearl. In NCLEX evaluation questions, always remember to choose objective, measurable, and perfusion-based outcomes like vital signs over less precise measures such as edema reduction or unsafe goals like rapid weight loss. Stable vital signs remain the gold standard for confirming improved cardiac output. Thank you. See you in next video.